Lung compliance is extremely important in critical care and anaesthesia. So compliance is the measure of distensibility, which is the ease at which something can be stretched. Lung compliance is defined as the change in lung volume per the unit change in transpulmonary pressure. It's important to understand about lung compliance because we rely on the concept quite a lot whenever we ventilate the patient or seek to understand the pathology that's going on inside the lungs. Lung compliance is best described using pressure volume curves of the lungs under static conditions, i.e. there's no gas flow and the respiratory muscles are relaxed. When these conditions are fulfilled, the transpulmonary pressure reflects in magnitude in elastic recoil pressure of the lungs. The slope of the pressure volume curve equates to lung compliance. Normal lung compliance is around 200 mils per centimetre of water. So we can see we've drawn the saline filled lungs here, which show increased lung compliance. Air filled, which is normal lungs, which is sort of a normal lung compliance of 200 mils per centimetres of water, as I've talked about. And then you can see at the bottom here we've got ARDS, or acute respiratory distress syndrome, which decreases your lung compliance, which actually means whenever you look at the axis, there's less volume at higher pressures. To summarise here, an increased lung compliance means there is greater volume at lower pressures. Lung compliance can be calculated by the slope of each of these respective curves. These plots are called hysteresis curves, which is the representation of unrecoverable energy. The lungs are not a perfect elastic system, and the pressure required to inflate the lungs is greater than the pressure required to deflate the lungs. That's why you've got this funny shape. Inspiration is represented by the bottom aspect of the curve, and expiration is actually represented by the top part of the curve. Just as an add-on note, specific compliance is estimated by dividing the lung compliance by the functional residual capacity. It is a measurement of the intrinsic elastic property of the lung tissue. Elastance is a reciprocal of lung compliance, so 1 over the lung compliance. So static compliance is important whenever we're choosing the ideal level of positive end expiratory pressure during mechanical ventilation. It's the lung compliance obtained during static or stationary conditions and there's no gas flow activity within the lungs. Static compliance monitors only elastic resistance, like the resistance offered by the alveoli being stretched and the interstitium and chest wall being moved. The static compliance, as we've already said, is used to select the ideal level of positive end expiratory pressure, and that's why this is important. This would be theoretically calculated by getting the patient to breathe via spirometer and also calculating the intrapleural pressure change using an esophageal probe. If you're to then plot a curve, it is the gradient of the slope that is the lung compliance. This is normally measured nearest the functional residual capacity, or the FRC, where the curve is steepest. So conversely to this, dynamic compliance is the lung compliance when obtained under dynamic or moving conditions, and that's when gas flow activity is present during breathing. Dynamic compliance monitors both elastic and airway resistance, and these things depend on gas viscosity and its density, the length and radius of the lumen of the tube involved that the patient might be breathing through, the gas flow rate of the gases you're giving them, and the flow pattern of the gas delivered. So pressure and volume hysteresis curves can show work of breathing. The mechanical work of breathing is obviously force times distance, but it's more usefully expressed as pressure times volume. Therefore, the work of breathing is the cumulative product of pressure multiplied by the volume of air moved over time. During quiet breathing, most of this work is required to overcome elastic resistance, so about 65%, and this inflates the lungs and provides a store of elastic energy that gets released during expiration, and it's therefore viewed as useful work. However, when you're overcoming non-elastic resistance like airway resistance, viscosity of the gas, etc., that accounts for about 35% of the work. This results in energy being dissipated as heat and viewed as wasted work. The area within your pressure volume curve in the middle of the previously drawn curves is the wasted work. The normal metabolic cost of breathing is about 0.5 to 1 mils of oxygen per litre per minute, but this could increase to 2 to 4 mils with hyperventilation. Finally, we're going to look at some factors that affect your lung compliance. So lung volumes affect your lung compliance. The slope of the pressure volume loop is obviously not constant. It is steepest around the FRC and then reduces at both low and high lung volumes. The FRC is affected by many factors including age, body posture and body size that will all in turn affect the lung compliance. That's why whenever we look at specific lung compliance, we divide the lung compliance by the functional residual capacity. Lung elasticity also affects lung compliance. This is due to elastin and collagen, which is in the lung tissue, and with aging there is a loss gradually of elastic tissue, and this increases compliance of the lungs. In emphysema, which is like COPD for example, you get loss of elastin from lung tissue, and this increases lung compliance. Compliance is reduced in pulmonary fibrosis due to those stiff, non-compliant lungs, and there's increased collagen deposition in the lung tissue. There's also pulmonary congestion due to edema. So finally, and most importantly, is surface tension. This is the most important determinant of lung compliance. The water in the alveolar fluid has a high surface tension, and this provides a force that actually tries to collapse the alveolus in. So lung surfactant that's produced by the type 2 pneumocytes will break up the surface tension, reduce the surface tension of the fluid, increasing lung compliance and making the alveolus less likely to collapse. The lung compliance when increased makes work of breathing easier. The effects of lack of pulmonary surfactant are obvious whenever you look at premature babies who get neonatal respiratory distress syndrome. Hopefully from this overview of the topic you'll see why lung compliance is so important to understand whenever you're going to mechanically ventilate somebody in theatre or in the intensive care unit. As always, there's more resources than this on the website, so check it out at propathology.com.